welcome everyone back from the one-week hiatus after the faculty meeting. I'm excited about our grand rounds scheduled today. I'm going to have Dr. Rodriguez in a moment introduce the speakers for the first slot, and following that talk, we will turn things over to the renal pathologist for biopsy conference. So without further ado, Dr. Rodriguez, thanks so much for doing the introductions.
Sure. So today's topic is an overview of health issues, including kidney disease in the American Indian Alaska Native population here in the WAMI region. Something I think we personally don't know enough about. So we have two great speakers today. Dr. Reya Mokiao is interested in social determinants of health, particularly food insecurity and health inequities with regards to kidney outcomes and CKD progression in pediatrics. Indigenous populations and community health are equally important to her, and she plans to work at the intersection of social determinants of health and kidney outcomes with Indigenous children and families. She was born and raised in Honolulu, Hawaii, and she's a second-year pediatric nephrology fellow, first-year fellow in Child Health Equity Research Program for postdoctoral trainees here at UW, and first-year MS Epi student at UW. And also participating will be Dr. Jason Deen, who identifies as part of the Blackfeet Nation, and as the director of the Indian Health Pathway here at the School of Medicine. He's an associate professor in pediatrics. In addition to being a general pediatric cardiologist, he's also specializes in the care of adults with congenital heart disease. His research encompasses preventive cardiology, arteriosclerosis in children and adults. He earned his MD at the University of Minnesota, where he also completed a combined internal medicine pediatric residency before doing a pediatric cardiology fellowship at Children's here at in Seattle, and an advanced fellowship in adult congenital heart disease at UW. So I'll turn it over to the two of you.
Thank you for that introduction. Let me just share our slides.
Yeah, I think I'm up first. So. All right, Okina Sistawasan. So that means hello family in my language. So Dr. Mokiao and I are going to talk about health issues in American Indian Alaska Native populations with a focus on kidney disease. Because as you all know, American Indigenous populations in this country experience significant health inequities compared to other races. So you can go ahead, Reya. So before we start, I just want to acknowledge that we are on Coast Salish land. These tribes encompass the Duwamish, Tulalip, Muckleshoot, Snoqualmie, Snoqualmish, and they are vibrant communities that continue to this day and are focused on the health of the next generation. So next slide, please. So quick overview. So I'll talk about, so in order to understand health inequities in American Indian Alaska Native populations, we need to know the historical context of how healthcare is delivered to them, just to understand some of the barriers that these communities experience. I'll talk very briefly about a smattering of health inequities, and then we'll get to the meat of the presentation with Dr. Mokiao's talk on kidney disease. So given that Dr. Mokiao and I are both pediatricians, this is the obligatory kid pick. So from left to right, these are Alaska Native children participating in traditional Alaska Native games, which is a pretty special event if you're ever up there. They're doing this kind of tug of war game, which is kind of cool. The next picture is a Coast Salish toddler in traditional regalia with a wonderful button dress. And then, this Coast Salish little one you may see in this area. So then, and then next picture is their tiny tots at a powwow in traditional regalia. So you may see these sorts of Indigenous children through Washington, Idaho, Wyoming, Montana. So, all right, next slide, please. So So American Indian people have a complex relationship with the United States, and this has led to an intricate constellation of federal Indian policies, treaties, and intergovernmental relations. There's a symbiotic relationship between the care of indigenous populations and the U.S. government. So really the services that are provided to indigenous people in this country are really guaranteed through treaties, executive orders, and other laws. So this results in a trust responsibility on behalf of the United States government to provide services to the American and Alaska Native people. For what it's worth, this trust has been tested through the centuries. Next, please. So really, in order to understand how healthcare is delivered, we'll just quickly go through some of the important health laws related to healthcare in indigenous populations. So first was the Snyder Act in 1921, and this set congressional appropriation for funds for indigenous populations. Then we had the Transfer Act in 1954, and this shifted the logistics to the U.S. Public Health Service, basically. And it really broadened oversight to include self-governance of tribes. So tribes, for the first time in 54, were able to say, well, this is what's best for my community because this is my community, and I'm going to provide some oversights to some of these things. Next was the Indian Self-Determination Educational Assistance Act. This was in 1975. And this broadened the funding stream to grants. So tribes were now eligible for grants, and we call these 638 grants, and other third-party revenue. So not only were they taking money from the Public Health Service, but they could also apply and get other grants as well to fund things like healthcare. Next, please. So a year later, there was the Indian Health Care Improvement Act, and this established urban Indian health programs. It was recognized that around this time, there were quite a few American Indian and Alaska Native folks living in urban centers. So this established those healthcare programs. Currently, there are 34 of them. Seattle Indian Health Board here in Seattle is one of the premier sites. It's also allowed the Indian Health Service funded clinics, as well as the tribal 638 funded clinics, to build Medicare and Medicaid. And then the Affordable Care Act in 2010 really increased Medicaid enrollment. It permanently reauthorized the Indian Health Care Improvement Act, which was pretty important because it went through congressional appropriations and had to be renewed, which was stressful. Next, please. And then the Indian Healthcare Improvement Act, which piggybacked on the Affordable Care Act, did a lot of things. So it modernized reimbursement to Medicare and Medicaid. It provided permission for tribal entities to purchase healthcare benefits for community members. It augmented the authority of the IHS director, and this is usually someone who is, if not from these indigenous communities, has a pretty intimate knowledge of those communities. It authorized hospice, assisted living, and long-term care, recognizing that in our communities, elder care is paramount. It's directed the establishment of comprehensive behavioral health prevention and treatment programs to try to tackle some of the mental health issues, suicide, depression, and those sorts of things that we see in our communities. Next, please. So despite this trust relationship, despite there being funding for American Indian and Alaska Native health for a long period of time, you can see here that the Indian Health Service has been chronically underfunded. And so this is the provider, the benefits per provider in all of the federally funded healthcare programs, Medicare, Medicaid, the Veterans Association. You see that the Indian Health Service is the lowest. So in this population with some of the most profound healthcare inequities, we spend the least. So really, some of this spending deficit is really a cause of some of these healthcare inequities. Next, please. So if you ask elder Native folks in this country, what are their barriers to accessing care? And this is the Kaiser Family Study. These are data from the Kaiser Family Study. And they've had to wait too long for appointments. So, the Indian Health Service is chronically understaffed. They've had to wait too long in the waiting room. So this, again, trying to increase revenue with limited staff. No transportation is a big issue. Cost also, and then the office wasn't open. So lots of subjective barriers born out from this chronic kind of underfunding. Next, please. And then we this is also these are also data from the Kaiser family study, but basically elderly Native folks in this country, have they stayed in the hospital? More have stayed, about twice as many have stayed in the hospital compared to any other U.S. race. And then they have more things like diabetes, which has kind of intimate intersection with you all's interest in diabetic nephropathy. More stroke, more heart attack, more coronary disease, more mental health issues. Next, please. So these are data from the Indian Health Service. So just looking at a broad swath of other healthcare conditions. So, and I'm sorry about the white centering for this slide, but compared to non-Hispanic whites, indigenous populations adults in this country are about a third more likely to have coronary disease. 17.6 of American Indian and Alaska Natives have diabetes mellitus type 2 compared to about 7.3% of whites. Nearly half of American Indian adult and Alaska Native adults are obese compared to 1/3 of whites. And American Indian and Alaska Native adults are 20% more likely to smoke cigarettes. Next, please. And we really see these health inequities borne out currently with the COVID-19 pandemic. These are also data from the Kaiser family study, and this is looking at serious risks. So we have this population that was colonized. They entered into a trust relationship with the federal government. They have consistently been let down and underfunded in regards to their healthcare needs. As a result, they have these health inequities that we've just very briefly talked about. And now when they're stressed, so say the pandemic, compared to all other races, American Indian Alaska Natives have worse illness. So we're really seeing some of these health inequities and the consequences of these issues really borne out today. Next, please. And this is, and if we look at disparities in life expectancy here in the WAMI region, because of all these issues, folks in the American Indian Alaska Natives in the WAMI region have about a 7 to 8 year decreased life expectancy as compared to all other races in this 2015 study. So we're actually seeing the consequences of this. I think that's all for me. So next slide, and I'll turn it over to Dr. Mokiao.
Thanks, Jason. So now I'm going to be talking about the burden of kidney disease in American Indian and Alaska Native people. I'm going to try to narrow it down to our Pacific Northwest WAMI region. And thinking about regional differences in the burden of kidney disease in AI and AN is actually a really interesting and important thing to think about, because multiple studies, including a study done by Dr. Yoshio Hall in 2011, looked at some regional differences or found regional differences amongst AI and AN that are on dialysis. So some of the things that he found was that, socioeconomic status varied, access to nephrology care pre-dialysis, mortality rate, and things like that were very much specific to the various regions. So now going forward, I'm going to talk specifically about what we know nationally, and then also what we know within the Pacific Northwest region. So national, in terms of national data, it's difficult to find incidence and prevalence of chronic kidney disease amongst American Indians. The most recent information that I found was from the KEEP study, which is the Kidney Early Evaluation Program. It was a national screening study funded by the National Kidney Foundation in the early 2000s. And the goal of that study was to screen patients that were deemed at higher risk of CKD. And so from that study, the prevalence of CKD amongst those that identified as AIAN was 29%. And this is probably an overestimation, just given the nature of this screening study, but it's the numbers that we have. We have more information in terms of end-stage kidney disease from USRDS data. So the prevalence of end-stage kidney disease in 2018, again, we're going to be comparing it to white because that's just the traditional way and the way that a lot of the literature that I'm going to talk about has compared it. But the prevalence was 3,163 versus 1,704 per million in AIAN versus white. And then the incidence was 504 versus 313 per million. Just showing that the prevalence and incidence of end-stage kidney disease is higher amongst AI and AN. So this is national data. Now we're gonna take it into like our Pacific Northwest region. And so we are Washington, we are part of Network 16. So that includes Washington, Alaska, Montana, Idaho, and Oregon, sorry, Wyoming. But this here is a graph from USRDS, the data query tools. And you can play around with it. You can like select different regions, different states, different networks, and you can look at incident counts, prevalent counts, and mortality rates, and stratify by different characteristics. So the following slides that look similar to this is from that data query tools on USRDS. So in the WAMI region in Network 16, this is a graph of the incident counts. So unfortunately, this is not an incidence rate, which is a lot more easy to interpret and to understand the scope of the burden, but this is what we have. So from 2015 to 2018, that big dark blue bar is the incident count of end-stage kidney disease amongst white, those identify as white. And then in that small little blue bar to the right is American Indian or Alaskan Native. And so the incident count for end-stage kidney disease amongst AIAN was around 100 up to 120 per year. Now looking at Washington State in particular, the incident count was around 30 per year. And interestingly, in Montana, their incident count was around 40 to 50 per year. But as you can see, the just this comparing the sizes of the two bars between white and American Indian and Alaskan Native, it seems to, when you compare the size of those bars compared to the size of the bars in comparing the network, and then also looking at Washington State, that American Indian and Alaskan Native bar is much larger. The primary etiology of end-stage kidney disease in Montana and in the entire region is diabetes. When you're looking at Montana data specifically, it's like 72% of AIN of these, 75% of these numbers are due to diabetes. And then when you look at it from a network level, around 60% of it is due to diabetes. So now moving away from incident counts and moving towards prevalence, so like proportions, we have information from our area from 2012, and this was the most recent data that I could find. So I want to bring your attention to the American Indian Alaska Native section here, and look to the far right when we have our network numbers. So American Indian Alaska Native people make up around 2.8% of the general population in our network, and yet they make up 3.3% of the prevalence and 3.1% of the incidence, so slightly disproportionate. But now I want you to look at, they broke it up by states. And so here in Montana, again, we have that 6.4% of the general population identify as American Indian or Alaskan Native, and yet they make up 24.3% of the prevalence and 21.7% of the incidence counts. So significantly disproportionate. Idaho, 1.7% versus 3.9% and 2.8%, slightly disproportionate, but not nearly on the scale as Montana. And then Alaska, Oregon, and Washington are all lower than the general population. So that is the prevalence and proportions that we have from 2012, which again was the most recent information that I could find. And now we're back to prevalent counts. So raw numbers from USRDS data. So this is our network 16, the WWAMI and Oregon states. And we have that the prevalent count was around 600 per year for American Indian Alaska Native. In Washington itself, it was around 160 per year. In Montana, it was around 240, 250 per year. And in Alaska, it was around 60 to 80 per year. Okay, and so when looking at these incident counts and prevalent counts, like I mentioned before, it's really difficult to understand the scope of the burden of kidney disease in American Indian Alaska Natives just by looking at the raw numbers, just because American Indian Alaska Native people make up a small percentage of the general population. But on the data query tools on USRDS, they did have a tool for mortality rate. So this here was able to really showcase the actual burden of mortality, which is helpful to understand the scope. So here we have 2015 to 2018, and we have our death rate per 1,000 person years. And in this dark blue bar, again, we have those that identify as white, and in this gray bar, we have American Indian or Alaska Native people. And every year, that gray bar is the highest bar, highest mortality rate. And so in the next slide, we're gonna look at 2018 data. We're gonna blow it up so you can see what the numbers actually are. So in 2018, in our entire network, 178.1 versus 128.1 when looking at the mortality rate between American Indian, Alaska Native, and white people. So yeah, this data just shows that the burden of mortality amongst American Indian, Alaska Native people on dialysis is significant. So when I think about the mortality of patients on dialysis, the next thing that comes to my mind is, well, what's going on with transplant in this population? So there have been multiple studies looking at transplants amongst AI and AN. And interestingly, AI and AN people are referred at a higher rate for transplant compared to other races, including those that identify as white. But despite that increase in referral rate, they are less likely to be placed on the waiting list, less likely to receive kidney transplants, and have a long wait between initiation of dialysis and transplant. And actually, amongst all of the races, AI and AN have the lowest annual percentage of kidney transplant after initiation of dialysis. So there are lots of there's a lot of things that we could talk about and explore when it comes to these transplant disparities to identify exactly why this is going on and what we can do about it. But this first bullet point, which is less likely to be placed on the waiting list, there was a study done in 2004, and one postulated reason was the fact that majority of the AI and AN participants lived more than an hour away from the nearest transplant referral center. And what they found was a majority of the patients that were referred completed the initial evaluation for transplant, but they didn't complete the advanced stages of the transplant evaluation, meaning things like the cardiac evaluation. And one potential reason is the fact that the transplant evaluation process for those people was just had a lot more visits, and the fact that they live so far away just made it inconvenient. So that's one potential barrier. And then in terms of these last two bullet points, this is something that is currently being explored, and a study done in 2013 wanted to figure out, like, what are the beliefs around transplant amongst American Indian Alaska Natives. And so from this study, it was a study that was actually based out of University of Washington, and they surveyed, they had focus groups amongst American Indian Alaska Native college students that attended tribal colleges and universities, or TCUs. And so from that study and from those focus groups, what some of the things that came up were that knowledge of organ donation was influenced primarily by direct family experience. So meaning those that had a family member that was on dialysis or received a transplant were more knowledgeable about the benefits of transplant, but also were more knowledgeable about the transplant referral process and the fact that there was a wait list, versus those that didn't have that direct family experience, didn't have as much knowledge, and they were actually more apprehensive about organ donation and transplant. Another thing that came up was that the traditional cultural beliefs about the body remaining intact for burial. So this is a direct quote from one of the participants. Well, most Indians around here believe that Indians should go back to the ground with what they were born with. So that is a traditional cultural belief that a lot of the participants realize does not align with the reality of the situation. And mind you that this is all college students, but a lot of the college student participants were actually supportive of organ donation because they understood that the burden of the disease and that their beliefs would have to start changing. And so there is this kind of cultural traditional shift that's going on amongst the younger generation when it comes to transplant and organ donation. Another important thing that came up was that there seems to be a mistrust of the local healthcare system due to high provider turnover, lack of a consistent provider, and also perceived inadequacies of their healthcare system as well, and lack of funding, like Dr. Deen mentioned. So as a result of this study, a lot of the focus group participants had recommended increasing knowledge and awareness about organ donation because they were willing to learn more, and they felt that the community was ready to learn more as well. Other than having their knowledge base being primarily based off of direct family experience, and another way that they got their knowledge was through TV. So like TV shows and things like that. So they had actually recommended having like TV, not ads, but what do you call those? Like PSA type of things on TV to increase knowledge and awareness. And then also they recommended outreach via the driver's license registry. So just giving more information and knowledge about organ donation there. Other next steps include continued integrated interdisciplinary and community-based approaches to these issues. So this here is a graph that many of you might have seen, which is looking at the incidence of end-stage kidney disease due to diabetes over time, and it's stratified by race. So on the bottom here, we have that dashed line, we have those identified as white, and then the solid blue line that's going down is American Indian Alaska Native people. And between 1996 and 2013, as you can see, the incidence of end-stage kidney disease due to diabetes amongst AI and AN significantly decreased by like 54%. The Indian Health Services implemented a comprehensive diabetes management program that really wasn't anything special or unique or innovative. It was really just screening for chronic kidney disease, screening for blood pressure or hypertension, screening for proteinuria, and treating it with ACEs and ARBs. And through that integrated, interdisciplinary, and community-based approach, they were able to have a significant impact on the incidence of end-stage kidney disease due to diabetes. So I illustrate this just to show that change is possible, change is necessary, and we can actually make a difference. And to continue making a difference, research is also important. So research looking into interventions and efficacy of interventions that are regional specific and then also community specific as well. Further research into identifying potentially modifiable risk factors, which is where I come in. And then also research looking at the potential barriers to transplant and trying to address them as well. Just a few things that are needed in this population. So that is really all that I had. I just want to thank you guys for your attention.
I will say that Dr. Mokiao is doing a wonderful study through the Strong Hearts study, looking at food insecurities related to chronic kidney disease in adolescents. So we should all be excited about that upcoming publication.
Thank you so much to Drs. Mokiao and Deen for this great presentation. We have time for some questions. I just see one question here in the chat from Laura about any data about use and availability of SGLT2 inhibitors in these groups.
That's a really good question. And I didn't see any data specific to American Indian and Alaska Native. I'm sure that hopefully that data exists, but I could not find any publications on it.
Great, and another question from Russ, question, obviously the Blackfoot Confederacy spans the US and Canada. Has there been a comparison between Canadian and US aligned populations?
Not a direct comparison, but in general, we know that in talking to our colleagues in Canada, that they don't see as profound health inequities as we see here, just because they call them First Nation populations, are better supported and better integrated into society. So there's less mistrust, there's more funding, which are broad social things that lead to an attenuation of the health inequities they experience.
Other questions? Oh, Rudy has a question here. Jason, could you comment on the community outreach to the AI community by UW now and in the past?
Yeah, I mean, I helped with that UW equity blueprint a few years ago. So there has been outreach. The problem is that in a lot of these communities, they're so used to what's called helicopter medicine, right? So docs from the tertiary care center helicopter into their communities, drop stuff down, extract it, and then they're gone, right? So in American Indian communities, what there needs to be relationship building. And this is where the hard work is, because not only does it take time and money, but you have to approach these folks with very little agenda, at least initially, and work very closely with them in regards to a needs assessment and things like that. So it has been challenging, I would say, because there aren't very many Indigenous faculty members and house staff here at UW. Now, compared to other big academic centers, we have probably among the most. But so our main activities have been working on pipeline programs, having the Indigenous faculty members and house staff be the face of UW, and just trying to kind of ingratiate ourselves into the communities there. They do help us with training of our medical students. American Indian and Alaska Native Health is a priority for the UW School of Medicine. So that's been one success in the outreach department that we've accomplished. But there's still significant barriers and trust issues in regards to even a academic center as relatively understanding as the University of Washington to these tribal nations.
And a final question from Dr. Lamb, do you see an expanding role for telehealth, including telenephrology?
I mean, what if these people don't have internet? What if they don't have a computer? So, I mean, telehealth is not going to save us as Black and brown people. It's only going to make things worse, to be honest with you. So yes, if you do telehealth within, the greater Seattle region, there's appropriate Wi-Fi there. People have computers and phones. They have money to pay for internet connections. But you go to Barlow, Alaska, how much Wi-Fi do they have? What if they don't even have electricity or running water? You know what I mean? So I think that we're going to be stuck with a lot more telehealth, but it's just going to add to the problem for some of these most at-risk communities. So yeah, I don't know. I'm pessimistic. So sorry about that.
Well, thanks so much to both of you for this wonderful presentation. Appreciate it. And I'm sure we could go on for much longer. Bessie Young says, excellent talk, thank you.